the views. Can you hear Khalid bhai?
Can you, Kambis, can you hear me?
Loud and clear.
Okay, I think we have a camera view, I see that there, and we will have a EUS and endoscope view on the other one. Can you do both separately?
Separately.
Are you ready there to start?
No, not yet.
Not yet.
Okay. और दूसरा ये कहो कि कैमरा जो है ना वो काम्बिस के बजाय ना स्क्रीन्स पे करें ताकि मैं देख लूँ क्या हो रहा है. ये रिकॉर्ड हो रहा होगा, ठीक है आपके लिए? हाँ, ओके, थैंक यू. FN तो करना नहीं है तो मैं इधर ही रख
Dr.
लेता
let me
हूँ
know
इसको.
when you want me to introduce the case when you're ready to start.
So can we go ahead and present the case, please?
So everyone, we're just starting. The first case that we have is a 35-year-old female patient who had history of epigastric pain. She was evaluated on an outpatient basis and her LFTs were slightly on the elevated side. So she had an MRCP. Data showed evidence of gallstones, dilated intrahepatic ducts, and dilated CBD, which was measuring 1.2 centimeters on the scan, along with CBD stones. So she was proceeded for an ERCP, and the ERCP had shown multiple filling defects, but a narrowing at the distal end of the CBD. So balloon sweeps could not be adequately done, so a stent was placed in its teeth. So currently we're evaluating the CBD stricture and seeing how long it is, seeing with the surrounding structure. So let's see what we find.
Okay.
Thank you.
We have a stent in there, right? You said?
We do.
Okay. Okay. So can we just put the camera on endoscope? If you can change everything there, we don't need the EUS screen yet. Just on the camera, just on me. Camera just on the scope, please. Okay. Screen pay.
Can we enlarge that image? The image that Dr. Hassan is on?
Complete view. What is it?
Just trying to get your image enlarged
Yeah.
so we can see better here.
So I just want to show the scope and how I hold it and where do I hold it from. So and then we'll switch back to this view. Oh yeah, this is good. Okay, so if you look at here, this is a umbilical cord of the scope. I put the scope right here, just like a regular scope. You guys hold that way. And here, that's a transducer right there. Transducer of the scope, of the EUS transducer is always on the opposite side of the umbilical cord. So this is how I hold the scope. Also, the upper esophageal sphincter in majority of the patients is gonna be from 15 to 19 centimeter from incisor based on their height. So what I do is I hold the scope close to 25 or between 25 and the 30. The reason for that is when the transducer gets to the back of the throat, if I'm holding too close and it gets to the area for oropharyngeal area and to pass the upper esophageal sphincter, if I have to move my hand back to hold the scope, then patient is going to be more irritated and you will have a problem with that intubating the upper esophageal sphincter. And if I'm holding it from too far, that also is a problem because I will not have a control of the scope and it would be too floppy to get through that. So holding somewhere between 25 and 30. Other way I do, the way I intubate the upper esophageal sphincter or I introduce the scope is I move it upside down like an oral airway. So here majority of the people go like this through the over the tongue and then go into the oropharyngeal area. What I do is, this is my way of doing it, not like you do whatever you are comfortable with. What I do is I make it upside down just like the oral airway. is done. So then I will go, can we put the EUS image too now? First the scope, yeah, this is good. So what I'll do is I'll go over the tongue. There is a little bit problem. This patient is a little bit at a higher level than my height where I would like it to be. And we can't move the bed down because it's a fluoro bed, which is okay, we'll deal with it. But always, as I mentioned earlier, be in comfortable position, patient should be in comfortable position, and your scope should be in comfortable position. So I'm using it like this, going over the tongue, and you can see if the patient is a little bit, I think, will be sedated a little bit more. I think you can turn the light on for it, please. And once, इसको छोड़ दो, थोड़ा सा रिलैक्स कर दो. आप इसको छोड़ दो, इधर से छोड़ दो, chin को छोड़ दो, not here. So if the chin is too high and it's being held up high, that could give you a trouble getting to the oropharyngeal area. That's what was happening. So I asked him to release the chin because he was moving that chin up for the patient's breathing. So that could be a problematic. So once I go into the back of the throat, I just let my scope flip, and that would take you through the upper esophageal sphincter. Once I'm into the esophagus, you can see that this is, I'm not just rushing through the esophagus. I'm slowly moving the scope through that, and the camera is at 45 angle. You can see I'm going into the, I see the GE junction right there. Once I'm into the stomach right here, look at my scope position. Scope is like literally straight. Wheels are facing upwards, and I'm holding the scope like this. There is no bent into the scope. Okay. Well, now what I'm going to do is, that's right there a GE junction, as I mentioned earlier. I'm at 59 centimeter right now of the scope. I'm going to go towards the opposite wall of the stomach. Once I get there, I will suction all the air out. You saw the scope, which is like at, I would say, 180 degree. We're going to move the EUS image bigger. Okay. And then I pull the scope a little bit back, and I'm going to rotate, and I see the liver. So you see the liver right underneath the transducer. Okay. So right here there is a liver. I'll keep that in my view, just pulling the scope back. So pulling the scope back so that 2/3 of my liver is on the left side of the screen and 1/3 is on the right of the screen. So when that happens, scope is straight. I'm going to bring the scope from 180 to 90 degree. So see what happens. Going. What happened there? Scope is straight. I got straight to the aorta. You see that? So once I am at the aorta, then I'll gently move the scope down into the stomach, moving my scope back and forth. And here, if you pay attention, I'm moving the scope back and forth. The reason for that is sometimes celiac comes off the side of the aorta. So here, aorta right there, celiac there, SMA right there. Other thing, if you look at it, my right hand is free. I can use my shoulders, my wrist to move the scope, and right hand I can use to use whatever accessory I need to use it, okay? So right here, celiac, I'm gonna follow the celiac, and you can see right here the left gastric is coming off. And celiac is right underneath my transducer. Whichever structure I want to examine, that needs to be right underneath the transducer between 5 and 7 o'clock position. So right there, celiac, left gastric coming off. I'm just gonna follow the main trunk. You can see right here, there are two coming off vessels. One is common hepatic, which goes downwards, and splenic. I will follow the splenic. By follow, I mean I'm gently gonna advance the scope. That takes me straight to the pancreas. You can see the pancreas right here, right there. This is a pancreatic duct, pancreatic body. You saw the splenic vein right, vein right here. She's coughing a little bit, so I'm gonna let that settle down a little bit. Splenic, ठीक है? Splenic artery right here, splenic vein right there. Splenic vein meets the SMV right here and making a portal vein right there. Portal vein is going down here towards the liver. So here, if I have to go towards this is the body of the pancreas right here. Duct is right in the center. I'm keeping that underneath the transducer to go towards the distal body and tail of the pancreas. I'm rotating it clockwise and pulling the scope back. Pulling the scope back. You see the duct right here. It's a little bit longitudinal view, which usually is because my transducer is a little bit crooked there. But you see the left kidney right here, pulling the scope back a little bit gently. And it's a very gentle movement. That's what I'm doing. Here, rotating to the right, and you can see the pancreas right here. Tail is falling down. And the spleen is right here. Left kidney, spleen, tail of the pancreas. If you don't see spleen and left kidney, you really have not fully evaluated the tail of the pancreas. Right there, you can see nice tail of the pancreas right here. Now what I will do is, I'll do the opposite of what I did earlier. Gently advance the scope, rotate to the left on anti-clockwise, bring the duct right underneath the transducer, rotating to the left. You can see the duct is right there, and now duct should fall down here. When it falls down there, that means it's going into the neck of the pancreas. Right here. You see that? Kambis, any comments? You can see that?
Very well, Dr. Hassan.
Okay. So right here is you can see that clearly it's falling down. So this is a portion of the neck of the pancreas right now. If you want to follow the portal vein, you can follow that towards the liver too. So just make your scope do whatever really structure you are trying to follow or whatever structure you are trying to examine. Keep that underneath the transducer between 5 and 7 o'clock position, and your job would become much easier. So here you can clearly see that duct, how it was falling down. Right there, right here, it will fall down right there. So that's going towards the neck of the pancreas. So now what I'm going to do is, I will go to the duodenal bulb. So we are done with our stomach station here. So that's my first station which is done. If we look at the endoscopic view to go into the stomach, I'm really inflating it. I don't want to do things blindly here. Once I go into the pylorus, Now, patients sometimes can have a little bit discomfort if they are not deeply sedated because you are stretching the stomach and you're resting on the greater curvature of the stomach. So now what I'll do is I'll get through the pylorus, and also remember that your transducer, if you're just looking straight onto the pylorus with the camera, you're never going to get into the duodenal bulb because your transducer is like 1.5 to 2 centimeter beyond the camera. And once you get into the duodenal bulb, look at the duodenal apex. You see the duodenal apex? You are going to put your transducer right at left upper corner of your duodenal apex and suction that. Once you do that, your scope is still kind of straight, and you do a right or left torque. And usually, you should be able to, we don't have a very good view here, but I think right here is the portal vein. That is the bile duct right there. There's some like junk in there. Right there. So usually the goal right there is like once you get to the duodenal bulb, rotate right or left to find a couple of structures there. One is either you find the bile duct, or you find the portal vein, or you find the pancreatic duct. Once you find one of those structures, then you can trace the rest. So here, Doppler किधर है इसका? Right there. Okay. If you look here, even though I'm right into the duodenal bulb, I'm at the apex. What I'm seeing right now is, उसका Doppler हटा दो जरा. First thing I get is, I get some floating stuff in here, and I think Dr. Kambi has already showed you one image which looked like a duodenal stent. So looks like this is a stent in there. Stent looks like a railway track, and this one is a ear shadow, and that is in the bile duct. Means the stent is really functional. This is a portal vein right here. Once I have found the bile duct, what I'll do is I'll rotate my scope, sometimes pull back and rotate it to the right to go towards the ampulla. So I'm moving the scope back a little bit so I can keep my bile duct right underneath the transducer, and just trying to keep a control of the scope here. I think I'm very close to the ampulla because I can see the duodenal wall falling here. PD is right there, and this is right there is the area of the ampulla. It's
Dr. Hassan, right at the ampulla, we noticed that there are some black linear structures that look like shadows. Are those real shadows, or is it something that you normally would expect to see in that area?
So this is if you look at here, if there is a air in the duodenal lumen or air in the bile duct, that can give shadows like that. So that's what it looks like here, these shadows. But another thing is like sometimes these small things we get distracted. So that should be also keeping in mind not to get distracted with those that easily. So here I get the point, like you see the shadow, there may be a stones and debris in the bile duct as well. And I think there is. This is more like just a shadow of the ear, because you can see there's a loss of echogenicity here. So I think that is a stone in there. This is a portal vein right here. If you look here, this is really a pancreatic duct right there. If I put a Doppler on there, you're not going to see any flow in there. So if I follow that from here towards the left, this is going to fall down. You see that? That's the neck of the pancreas. This is the part, second area from the duodenal bulb where you look at the neck of the pancreas. If you guys remember that, what I said is, duct is gonna come here, pancreatic neck here, body is somewhere here, and tail is somewhere here. This is from the duodenal bulb. Now I see the pancreatic duct. If I follow that towards the right, I'm going toward the ampulla, and when we get close to the ampulla, I kind of lose it for multiple reasons. One is the shadow from the stone here, shadow from the stent here, and also air in there. So, but I think we are able to get at least a good view of the pancreas, and I don't see any major abnormality. It's hard to appreciate stricture in this area. The reason for that is there's too much shadowing there. There may be a little bit thickening of the wall, but I don't see anything bad in there. I don't see the mass there, at least not an obvious mass. So I think it may be she had the stones, she keeps passing those stones. There may be an inflammatory process leading to the thickness of the bile duct. So right there, we saw that ampulla. If I want to follow the bile duct towards the liver, I will keep that bile duct right there. Gently advance the scope. You can see the stent even more clear right here. Follow that towards the liver. What I mean by following is I'm rotating the scope anti-clockwise while keeping that bile duct right underneath the transducer. By the way, this is all air into the bile duct, and that's why it's giving a lot of echogenicity and not able to see the whole lumen properly because of the air. But if I keep following it to the left, while releasing my big wheel away from me slowly, and keep rotating the scope downward anti-clockwise, I end up into the liver hilum. This is all liver right now. You can see that. That's somewhere the liver hilum is right here, but there's a lot of air, and you see the debris, some small stones in there too. So from there, now I will go back towards the area of the ampulla. I still see that that debris in there, and going back right there until I get to the ampulla. Other thing, if you look at it, I'm controlling my scope mostly with my left hand and with my shoulders. My right hand is free. If the scope is torqued like this with the right hand, my hand is not free. I can't do it, and it's unstable scope position. So that's what you want to avoid. Now, from duodenal apex, I'm going to go into the second part of the duodenum. If you look at that, I will very gently follow the lumen. It's not those useless movement which some people do like this. It's a gentle movement, and just get through that. And if you're having a trouble getting through that, then you can always come back, start over from the stomach. But if you look there, I'm very gently moving the scope down there, and now we are in the second part of the duodenum. If I don't see the ampulla, it's okay, no need to worry about it. Here I'm going to try, once I'm in a short scope position, what we call, then I will move big wheel towards me, move the scope right or left. My goal is to find the aorta. You see that? I found the aorta. Aorta is the structure which is in the middle of 5 structures. The way you can tell it is aorta, it's a tubular structure, and really I'm not able to compress it. My scope position is like this right now. Scope is straight. If I go to the left, first thing I will find is, I will find the IVC, easily compressible. You can see that where the arrow is. Again, I cannot stress that enough. Scope needs to be comfortable and in a good control position, so your right hand is free most of the time. From there, if I go further to the left, you can see the right kidney right here. Right kidney, IVC, aorta. Once I see aorta in this position, I pull the scope back just a little bit, and then rotate to the right. That takes me straight to the pancreas right here. You can see the stent right there, and that's a bile duct right there. Pancreatic duct is right underneath, and this is the area of the ampulla. So from here, I need to rotate the scope really a little bit more to the right to see the uncinate process. Once I see these mesenteric vessels, which is the superior mesenteric vein, that is the area of the uncinate process right there. The vein there, artery underneath, and sometimes you fall back, which is okay. If you fall back, you can always go back, and I can feel like that I fell back. So right now what I'm going to do is, I've seen the head, I've seen the uncinate, bile duct, pancreatic duct. Now I'm going to do that maneuver what I mentioned, like a 20-second maneuver to see the whole pancreas in one go, and that would be the area where you see the neck of the pancreas from the third station. So I will find my here aorta right there, rotating the scope to the right from there. This is uncinate is coming right there. If I rotate further to the right, you can see the pancreatic duct nicely right there above the arrow. From there, if I go to the left, I see a little bit shadow there. That is the bile duct, and that's a stent shadow there. But you can clearly see the pancreatic duct right here ending up into the duodenal wall. So this is the area of the ampulla. From here, if I rotate further to the right, I see the mesenteric vessels, and that is the uncinate process right here. From here, I will follow this pancreatic duct backwards, pulling it back. You can see coming into the through the head into the neck area. Once I have seen this area, I'm satisfied. It's a little bit maybe a bigger dilated, but I think we have a little bit bigger image as well. So it may be 4 millimeter or 5 millimeter, but it's okay. So I see it. It's fine right here. So I'll pull it back a little bit. Now I will forget about this area. I'm going to focus more on this area because you move the transducer a little bit, it can change the orientation differently. We saw the head area. This is the duct right there. I'm going into the neck area, gently pulling the scope back. Portal, this is like right here, superior mesenteric vein, superior mesenteric artery. If I follow that, I will end up into the portal vein, but I'm more interested in the pancreatic duct right here. That's the area of the neck. This is the third place where we are seeing the neck. Now I gotta make sure my views are unlocked. I'm gonna slowly follow that go back, and you can see the portal vein is coming right here, but I still did not lose the duct right there, coming back, and I'm about to fall into the stomach, and I may lose it briefly, which I did, but I will bring it back. You can see the left kidney right there, pancreas is right underneath, and splenic spleen is right there, and tail of the pancreas is right there. So we saw the whole pancreas, pretty much whole pancreas all the way from the ampulla towards the tail of the pancreas. So right here, this is spleen. As Kambi's mentioned, that spleen looks like liver, but without ducts or without any major vessels in there. From there, now we have seen all our stations from the duodenum. We saw stomach station, we saw duodenal bulb station, we saw second part of the duodenum. I'm going to come back to the liver area where we started from, and keep the scope again in neutral position. I will pull back into the esophagus. Once we are close to 30, you see, which is a beating, that's the left atrium. Once you start seeing that, bring the left atrium towards the left side of the screen. You can see right there. Other side. So this area, pulmonary artery right there, that's a subcarina. So that's how you can evaluate the subcarina. From here, if I start looking downward, just rotating the scope, and I get to the aorta. I'm at the aortic arch. When aortic arch comes, right under the transducer. I'll move a big wheel towards me a little bit, rotate the scope to the right, and that takes you the AP window. The aorta, pulmonary artery, and AP window there. If you want to further interested in doing further exam, you can pull it up. You can get to the left carotid and subclavian, and this is you see this thyroid gland, which looks like really like a pancreas tissue sometimes, but we're right at the neck, right at the oropharyngeal area, and she may have something in the thyroid, small cyst there, right there. Okay. And we are out. Okay. Kambi's questions?
That was a beautiful demonstration, Dr. Hassan. Thank you. So one question I had was, you evaluated that pancreatic duct in the head of the pancreas in the uncinate process, and then you were able to, with one motion, track this down into the body and the tail. Does that effectively rule out a pancreas divisum?
Yes, I think it effectively, if you can follow that from the ampulla all the way to the tail, that pretty much rules out pancreas divisum. Yeah.
And Dr. Hassan, what would you expect to see in a tumor of the bile duct in a patient like this? So assuming that it was a cancer, what would your typical findings be?
So bile duct, like there was a lot of artifact. It was from stone there, air there, and stent in there. Usually what you see, if it's a bile duct tumor, you will either see a mass around the stent, or you will see a thickening of the bile duct. Thickening of the bile duct can happen for two reasons, either an inflammatory process or a malignancy. Whenever the thickness is because of malignancy, you don't see any wall layers of the bile duct. But if, however, it is an inflammatory process like cholangitis, you see 3 layers of the bile duct wall. There are 2 a little bit hypoechoic and 1 in the center hyperechogenic. So that shows it's an inflammatory process. But usually you see a mass or you see a very thickened bile duct which has no wall layer differentiation in there.
Thank you, Dr. Hassan. One last one. What on EUS would make you feel like there is a stricture in the bile duct in a patient that already has a stent, assuming that you don't have as much air artifact in there? So what features morphologically would you look for that would tell you that this is a stricture?
So when the walls come really collapsed onto the stent, they are like hugging the stent, and they are like, whenever you move, even you're moving the transducer around, you don't see the gap between the stent and the wall. So that is the area, and you will see right above the stricture, the wall, this separate, and you can see dilated bile duct. And it's gonna be a thickened wall there, wherever it is hugging the stent tightly. If you don't see a thickened wall there, likely it's, even if it is a stricture, it's a fibrotic, it's not a malignant stricture.
Thank you, Dr. Hassan.
Sorry.
How can on EUS we differentiate between ear bubbles and stones?
No, I think, yeah, it's probably, I don't even see a major stricture. I think if it
So
is a
Dr.
stricture,
Hassan,
it's a fibrotic or inflammatory stones and ear in the bile duct and with the stent. So I think we just need to dilate it. Yeah, pretty much. Dilate, usko stent nikal ke usko dilate karna hai and then just clean out.
So, hi,